Hi, I'm Rand Bennett. Jim Hilgers and I are here in Utah. We went skiing this morning. We're going to do a little golfing this afternoon. We were sitting around at lunch with nothing better to do, and we thought, what the heck, let's make a video. So we made this little video to show some of the arch wires and appliances that we use in our practices. Now I know you're not going to believe this, but I'm telling you the truth. We did this all ourselves. That's right, everything, special effects, all of it. It's going to amaze you. I know I'm amazed every time I watch it. You know, I don't think Spielberg could have done better. Anyway, sit back and relax. We hope you enjoy watching this and have as much fun watching it as we had making it. See ya.
Talk about building an ideal lower utility arch, and then following that we'll talk about building an ideal upper utility arch. Before we do that, basically we'd like to look at the components of the utility arch itself and talk about each, and then we'll talk about how this is fabricated in the mouth and how the arch is formed and adjusted to be able to create the arch that you see here. Essentially, it is the utility arch is one of the most sectional arches you'll ever use, in that it treats each of the molars as a separate segment. It treats the incisors as a separate segment, and it allows for obviously movement in the buccal segment because we're going to bypass those teeth. Now I have a tendency to use a lot of continuous arches, but it's a wonderful arch in early treatment. It's a wonderful arch length maintainer just before the E's are lost, and it's an ideal arch wire for advancing and aligning incisors with torque control. So it's an arch wire that we still use a great deal in our mechanics, but it has to be formed properly, and that's what we're going to talk about at this point. Essentially, as you look in the back here, what you're going to see is that the molars are expanded. We'll show you this over a model in a few moments, but are expanded greatly in the posterior segments. And we have about 40 to 45 degrees of torque in this 16 square wire. There's going to be some loss of torque control, so we keep the arch expanded to keep the molars out, to keep them from rolling inward as we upright them. And as you can see, both of these legs are parallel. The simple uprighting of the tooth will distal rotate the lower molar. There is a flaring at the mesial of the lower molar tube. This will get this small bend away from the tissue that is around the lower molar, and you'll have the same flaring, slight flaring at the lower canine region, so as the incisors go down and you have an erupting cuspid or a cuspid that's fully in place, that this doesn't impinge upon the tissue around the canine area. The anterior segment is very tightly contoured, as you can see. We don't flatten this out at all. And although you can't see it in this photograph, there's about 20 degrees of labial root torque that's been placed in most of these arches, so that we have a little bit better torque control of the lower incisors, and a tendency to hold the lower arch back as we intrude them. Each of these bends is about 2 to 3 millimeters away from the distal bracket on the lower lateral incisor. That gives us some play so that we can move the arch back and forth in fitting it. It doesn't have to be tightly adapted to the lateral incisor bracket, and it allows us to make some adjustments in here if we have some alignment problems, so that as the teeth are aligned and engaged into the bracket, we have a little bit of room to move on the wire in the anterior segment. And then this is again carried over to the other side. One of the key issues is that we want to keep these steps very shallow. I would say 4 to 5 millimeters would be the maximum that you'd want to have in terms of the height of this, and the only purpose really is to get it down into the buccal vestibule so that it can't be deformed by the forces of occlusion. We're going to use a typodont in lieu of a patient's mouth in order to show demonstrate the building of this lower utility arch. But essentially the components involved with it are the same as they would be if we were in the patient's mouth. I use only 2 instruments in order to bend the arch wire. The first is a Howe plier, a simple Howe plier, that has about a 5 millimeter vertical beak. This allows me to bend that right angle bends or the step in each of the utility arches at approximately the same length. So if you want to choose a Howe plier that you'd use to bend it and to actually place the appliance, we would want to have one with a beak of about 5 millimeters in height. And then the other plier that we would use, of course, would be some sort of a wire cutter to clip the wire as we finish it. We start off by using a piece of 16 square blue azurlor wire. This is non-heat treated at this particular point, although we do heat treat the distal legs on the arch wire so that we have a little bit more rigidity, and we'll demonstrate that as we get toward the end. So before we go into the patient's mouth, we'll make the first step bend. So we bend up and with our other finger, with our thumb, push down so that we're just starting off with a simple right angle bend. So if we look at this from the side, you can see this is the beginning of the arch. This is before we go into the patient's mouth. And realistically, if the lower arch is somewhat symmetrical in nature, we will only need to go into the mouth twice in order to build the arch. The first thing we'll do is to place it into the gingival tube. And place it right up so that it is abutted against the gingival tube itself. We'll bring it around and make a pencil mark about 2 millimeters distal to the lower lateral incisor. And I'll turn this up in just a minute so you can see it. So we'll make our mark right at about 2 millimeters distal of the lower lateral incisor at this particular point. Okay. We then take this out of the patient's mouth, and we're going to make our next step in the anterior segment. Now, instead of making the entire step, I want you to take this and hold it with a Howe plier and simply make the upward bend. So I'm holding it right at that mark, and I'm going to bend upward only. So we're going to stop right here. This is crucial because it's at this point that we're going to place the labial root torque, the reverse torque in the lower incisor region. So if we just lay it down here, you can see that I have my vertical step in the posterior. I have this segment that I have measured to the distal of the lateral incisor. We have bent back up and we stop at this point. We then take this wire, and if you can picture this, instead of bending straight down in the same plane that it would, which would be essentially along this axis right here, which would put zero torque in it, would just simply be a step in the back and a step in the anterior. We're going to be coming around the arch to the left-hand side of the patient in this form. Instead of bending straight down in the same plane as you see with this pencil, we will push the arch wire off to an angle. So if this is the straight plane, rather than putting it straight down in that angle, we'll bend it off at about a 20-degree angle. So as you can see right here, the amount that you have from the straight plane to the angle that you have bent this inward will be the approximate amount of torque that you're placing in the lower incisor region. Hold it at the top, or hold this anterior vertical step, and I will use my forefinger and thumb to create the anterior contour. Again, as you remember, this is going to be very tightly contoured in the anterior. And if you would check this from the side at this point, you would see that we've placed approximately 20 degrees of labial root torque in the lower incisor region. So, and by defining the amount that you're bending inward on this, you can place 5 degrees, 10 degrees, 30 degrees, whatever you wish in the lower incisor region very accurately. This is a little bit tougher to do when you've got rubber gloves on, but we form the anterior section. We're now going to go back into the mouth for the second time, and rather than trying to fit this long segment of the wire, of course, into the mouth, what we simply do is lace the anterior portion over the incisors, and we leave this portion of the wire essentially stick out around the outside of the cheek area. So this is going to be outside of the patient's mouth. We will bring it up to the to the lateral incisor, we will mark 2 millimeters distal to the opposite side, and at this point make a simple, doesn't seem so simple, does it? A simple down bend. In other words, we're going to make it down and then bring it back up so that we have that step. Now, if you look at this from the top of the arch, what you'll see is that that this is somewhat inside. You're going to have, you have this side flared very slightly, but because there was torque in the anterior segment, when we bring this down, it's going to be inward somewhat. This is going to be compensated for ultimately as we start to flare these buccal segments, so we don't worry about it at this time at all. We have our 20 degrees of labial root torque in here. We don't want to take any of that out. We accept that this is going to be inside at this particular time. We'll just look across the span across the utility arch, and usually you can eyeball the length on one side versus the other. So as you can see here, if I looked across the arch in symmetry, I would probably start my next bend somewhere at this point right here. My staff usually bends this arch wire, and what they like to do is to take a piece of, either on the treatment chart or on a piece of paper, and they will make a small mark for one side, as you see here. They will bring the opposite side over and mark that exact same length on the opposite side. And again, this is assuming that there's relative symmetry in the mouth, but you certainly have some play with this as you go through it. And we will then start at that particular point and make the last step bend. Okay, I'm going to set this down for you, and of course at this point the arch is simply a measured arch. What we have in it is none of the contouring and flaring that we talked about before. That's all going to be activated at this point, but we have a proper length on each of the sides. We have our labial root torque, we have the right size steps, and we can then go ahead and clip the arch wire at the opposite side. Normally I leave the distal legs about 5 to 8 millimeters long, just enough to get it through the gingival tube. We don't want to have this too long, because as we start to place the utility arch, the longer the wire in this leg, the less rigid it is, and the more likely that you're going to take some of the tip back out as you place the arch wire itself. So this is the beginning form, and as I mentioned before, when you look at this from the top, on the left-hand side you'll have this pretty much straight up and down. If you come over to the right-hand side, you'll see how this is bent somewhat inward, where we're going to compensate for this now. And essentially we start on the left side of the arch and work around to the right side in order to do the adaptations that we need, that are necessary to place the arch wire in the mouth. And it's going to be done by making a series of bends, starting in the middle of the leg on the left-hand side. So the first thing we'll do is we'll take this and hold it in the center of the leg, and we will twist the posterior segment inward. So what you're going to do is you're going to start to place torque in the lower molar region by twisting the center. The advantage of this is that we're also starting to create some flare around the lower molar region. We then come forward and hold at the superior part of the anterior bend, and we will flare the anterior segment out slightly. So what we're doing is, again, adding a little bit more torque in the molar region. We have slight flaring at the incisor area, around the cuspid area, and we have a greater flaring back in the lower molar area. Now if I were to go back and hold this in the lower molar, you'd see that we have about 45 to 50 degrees of buccal root torque in the lower molar at that particular time. Side and hold the top of the vertical bridge on at the other lateral incisor position, and we will now compensate for this inward bend by flaring the anterior segment out slightly more. So if you look at it now, we start to create some symmetry, at least in the flaring of at the lateral incisor region. And again, I will hold mid-bridge in order to place some buckle rip or some buckle rip torque in the buckle segment, and to create more flaring in the posterior segment by the molar. And normally I'll take my forefinger and thumb and simply lightly contour the buckle segments so that it doesn't go straight back and takes a little bit more of the arch form that would exist in the mouth. Now you start to see some of the symmetry that we showed you in the first utility arch that we put down. Again, we keep the anterior segment tightly contoured. We have some slight contouring in the buckle segments. We have this nice flaring, a little more at the molar than at the canine area. And now we want to come back and expand or flare out or butterfly out these posterior segments, and at the same time we want to put some tip back and rotation in the lower molar region. Normally, by holding at the vertical step and bending inward and down, we'll put about 45 degrees of tip back. And of course the tip back is totally dependent upon the need to intrude the incisors. This is an arch that can be used to stabilize incisors, can be used in anchorage for floating the cuspids back. The amount of tip back and the amount of torque that's placed in each case might vary somewhat. But this is the standard utility arch for a Class 2 Division 1 or Class 2 Division 2 deep bite. Now, what you'll notice at this point is that we've made the two legs parallel to each other. We don't need to put actual distal rotation in the lower molar, because as the molar uprights, the cortical function around the tooth has a tendency to distally rotate it slightly anyway. If we put too much distal rotation in it, the tendency is to rotate it inside the lower second molar. So we make these two legs parallel to each other. And then the last move in terms of building the arch is to take it at the vertical step, and without affecting the anterior contour, to expand it greatly in the posterior segment. So what you're seeing me do right now is to butterfly this out so that we have about 1 centimeter of overall expansion from molar to molar. So when we look at this, again, we'll keep the anterior contour tight. Again, we're going to keep this anterior contour tight. We're going to flare these greatly starting at the anterior vertical step so that we have about 1 centimeter overall expansion in the molar region. So if I would bring this particular patient, our typodont patient, into the arch, you can see that if you would set it over this, you can visualize the amount of expansion that would be on each side, about 5 to 6 millimeters of expansion on each side as the arch wire is placed in. This acts to hold the lower molars out and teaches them to hold the roots out instead of tipping the crowns inward. So you need expansion and torque, but since the lower molars are not tied to anything other than the lower incisors, the expansion teaches the tooth to hold the crown vertically as the lower molar crowns or roots are tipped somewhat buccally. And we're not interested in really burying the roots of these teeth out in cortical bone. They are already there. What we're trying to do with the arch is to prevent the arch from narrowing as the lower molar goes inward, which can happen if you have a little bit too much narrowness in the lower utility arch itself. Now, let me take this typodont away, and I'll show you the last move that we make. We use a simple Bic lighter that we have in the office, and I use this to heat treat or to dead soften TMA wires, to dead soften night tie wires so that we can bend them over. We also use this little Bic lighter to selectively heat treat a portion of the arch. And the portion that we want to heat treat is the tip back that we have. We want a lot of rigidity in this area so that as we place it into the tube, we don't lose our intrusive force, which happens with a non-treatable blue azurloy wire. So we use a little flame, and I'll heat treat just this portion of the leg until it turns to a straw color on both sides, a real light straw color. And what you'll see then is that at that point you have a great deal of rigidity in the posterior segment, and you can place this bend into the tube with lose virtually none of its activation, and yet we've got a nice flexible, adjustable, adaptable wire from there forward. So the selective heat treating allows us to keep the nice forces in the anterior, the torque control to be able to engage the incisors, and yet have the rigidity in the posterior segments as we need. And then the arch wire is ready for placement. Wire is ready for placement. Again, we'll use a Howe plier to place the arch wire, and one of the keys to this is that we want to protect the tip back bend as we place the arch wire in. So in order to place the arch wire in the tube, I will hold right at the vertical step and slide the arch wire into the tube itself. This, of course, is going to bring the utility arch up on one side. We then place the other side by maintaining that same, protecting that bend in the posterior segment, slide it back into the tube, bring it up out of the vestibule, and start to engage it in the lower incisors. In all cases, I bend over the utility arch because one of the worst things that can happen is that with the forces of occlusion or food or the kids playing with the utility arch, they pull it out of the tube slightly, it deforms, and then it starts to throw the molar in any region. You can handle the arch length changes by simply opening up the arch as the upper molar uprights or the lower incisors come forward. So we do that with internal adjustments in the mouth, but we will bend over the end of the utility arch so that's very securely held in place, and we're not, and it certainly reduces the amount of emergencies that we're going to have with this wire. We're going to spend a few moments talking about placement of the arch in the mouth. Obviously, we want to be able to place the lower utility arch without taking out activation, and yet it's a little bit tricky to get it in without impinging upon the tissue and without poking the patient. Essentially, we're going to hold the distal leg on the lower utility arch, the vertical step on the utility arch that has been heat treated, at the top of the vertical step, so that as we place this into the tube, we don't take any of the tip back out. So we're protecting that bend as we place it into the mouth. It's actually more difficult to place it on a typodont than it is in the patient's mouth, but as we slide this lower utility arch in, what we're going to see is that immediately, and I'm going to show this from the front now, because of the torque, it's going to lift itself up on the opposite side. So you're going to see your torque, and there has a tendency to have some impingement in this area over here. So we simply slide all the way back into the tube, and rather than coming around to the opposite side and starting to fit this portion into the tube so that the anterior segment of the utility arch drops down into the vestibule, what I'll do is come and put one tie on the incisors to stabilize that before I go to the right-hand side. So this will just make it a little bit more comfortable for the patient. So we slide it in all the way back against the molar. We're going to have this bias that you're seeing to the occlusal plane, and we're going to then bring it down and engage it with one single tie to hold the arch wire in place. So we're going to bring it down, and at this point we will use a brightly colored red O-ring and engage the anterior portion. That's up. So what we've done is, with our hemostat, we're not interested in engaging the arch wire perfectly into the bracket. All we want to do is stabilize the anterior segment so that the portion around the cuspid doesn't dig into the tissue over here. Now, as you look to the right-hand side, of course, this free-floating portion of the utility arch is still going to be in the mouth, and we're at this time going to take the opposite side and protect that right angle bend at the top of the utility arch. We glance it forward and slide this back into the tube. Now we have the ability to stabilize the anterior portion of the utility arch, to move it side to side to make sure that the bends are right up against the tube in the back. And normally at this point what I'll go ahead and do is to, in the mouth, is to tip down each of the ends of the utility arch so that it can no longer come forward if we're happy with the overall fit of the arch itself. We then come back and engage each of the brackets in the anterior. If a tooth is completely out of alignment and we can't engage it, we just simply lace over the top of it, and as arch form works itself out down below and we start to create some space in the buccal segment, in subsequent appointments we can engage the anterior portion of the utility arch. So we go ahead and finish engaging this and making sure that we've got our torque placed into that area. Now, only one other thing that we should mention is that once we have the arch entirely tied in, periodically you'll see impingement along the buccal segment. If you need to flare this out a little bit more, we don't want to do so by simply grabbing the anterior portion of the utility arch and bending it outward. What that will do is change the torque in the molar region a great deal. So what we do in the mouth is that we can flare this, but we will put very light pressure to hold the utility arch against the patient's tissue. All we're trying to do is make sure that the bend occurs in the anterior segment and not in the posterior segment. So we can hold it very gently against the tissue, and we can flare this out. If you took the utility arch, you'll find out that the flare is, if you took it out of the mouth, you'll find out that the flare is increased slightly here, and yet we haven't affected the tip back, torque, or rotation in the lower molar area. So we can very slightly bend this out, and then I will go along the buccal segment with my Howell plier and contour it lightly so that it's not impinging upon the tissue at all in this area. We don't want it out too far, we don't want it in too close and impinge upon the buccal tissue. So by simply working with it a little bit after it's all entirely engaged and bent over at the molar, we can adapt the buccal segments a little bit closer so that it isn't irritating to the tissue. Okay, now we'd like to discuss the fabrication or the building of an upper utility arch. As you can see, in deference to the lower that we've built before, it looks quite a bit different in its shape and form and contour. We want to talk about how it's built, of course, but we also want to talk about the whys and wherefores of each of these bends. The best way to really describe the difference between the two arches is maybe to look at them side by side. To compare the two arches to each other, you can see that they have totally different shapes and forms. In the lower utility arch, where we have the lower molars, molar legs running parallel to each other, in the upper utility arch we have a great deal of distal rotation. The distal rotation of the upper first molar is one of the most difficult things to maintain throughout orthodontic treatment, so this has to be very active in the utility arch, whereas this is not quite so difficult in the lower arch. The simple uprighting of the lower molar will rotate it slightly distally. Whereas we've had a great deal of expansion in the lower utility arch, about 1 centimeter of expansion to hold the lower molars out in the developing dentition. In the upper arch, it can be a little bit more ideally formed so that the arch form and shape can be more ideal in nature rather than the expanded or butterflied arch that you see in the lower arch. In the lower molar, we have a flare away from the tissue. We have that same flare away from the tissue up by the upper molar region. The difference in the canine area is that now we're going to come back into the buccal vestibule. So instead of flaring it out as we have in the lower incisor region, in the upper utility arch it is bent inward so that this portion of the utility arch is not out into the vestibule or into the upper lip. So whereas we have flare, flare, on the upper we have flare outward and then flare inward. We have 20 degrees of labial root torque in the ideal lower utility arch. In the upper utility arch, we have no torque at all. This is basically maintained in the bracket slots themselves, and since we're using a high torque appliance, we want to typically not add more torque to the anterior region. It would be not only difficult to engage, but it uses a lot of anchorage to do that. So we have 0 degree anterior torque, and then again continuing on to the opposite side in the distal molar rotation. So indeed, two very different arch wires altogether, fabricated much in the same way, but it's the way that we're going to twist and place torque and rotation and tip into the arch wires that is different. The essence of the wires themselves is the same, but as you can see, very different in form. typical wire of choice for an upper utility arch is an 016 by 022 Azurloy, again unheat treated arch wire. This is again made by Ormco Corporation. The reason for 016 by 022 1622 wire instead of 16 square really has very little to do with the intrusive effect. We found that we can intrude the upper incisors very effectively with 16 square wire, just as we can the lower incisors with 16 square wire. The reason for the larger wire has mainly to do with the torque control in the upper incisor region. Normally when we're using this arch wire, we want to not only intrude the upper incisors, we want very, very active torque control in that region. So the usual wire of choice is a 1622 non-heat treated Azurloy wire. It can also be, this arch wire can also be fabricated out of TMA. At times it doesn't need to have the steps that we've placed into it. But what I found is that from a purely economic standpoint, this is a nice arch wire to use in most instances. Again, we'll use our typodont patient, and to begin the arch wire, we're going to use the same Howell plier with a 5mm beak that we use to build the lower utility arch. So before we go into the patient's mouth the first time, we'll make our first right angle bend and step. As you can see here, that again will be approximately 5mm in height. By placing this into the upper molar tube, and then as it extends along the buccal segment, we are going to mark right over the distal of the upper lateral incisor bracket. Now, even though we want this wire slightly away from the bracket itself, we're going to show you when we make a Z bend on this wire that bringing it back and then in will give us that 2mm placement away from the lateral incisor bracket. So the measurement is marked right at the distal of the upper lateral incisor. So now we have the mark on the distal portion of the Howell plier. We're going to bend inward, make a very strong, about a 45-degree bend, and then back outward, so that in effect what we're placing in the anterior portion is a Z. The reason that we like this Z built into most upper utility arches is number one, that this upper portion of the utility arch will accept class 2 elastic, so we use this quite often in early treatment cases. Rather than attaching to a bracket, we'll put the class 2 elastic around the Z bend itself. But more importantly, this gives us some extra wire to bend if we're advancing the upper incisors. So as we flatten this out, we can torque the upper incisors slightly and advance them with the extra wire that's incorporated into the utility arch itself. What you'll see now. So as you can see, if the vertical step on the posterior aspect of the utility arch is butted right up against the tube, we have made our first beginning bend right at the distal of the upper lateral incisor bracket. By the time you place the Z bend in the anterior section, it will give us the same play that we have on the lower utility arch, with the wire being about 2 to 3 millimeters away from the distal of the lower incisor bracket, or the upper incisor bracket. Again, we're going to lace the anterior portion of this straight wire into the brackets on the upper incisor region. We'll have the left-hand side, from the patient's standpoint, up against, or a couple of millimeters away from the lateral incisor bracket, and when we mark on the right-hand side, we're going to have to give that same space. So we don't mark right at the bracket on the opposite side, we mark about 2 to 3 millimeters away, so that we can start our Z bend at exactly this point. It's not necessary to go back into the tube. We can still lace this across the incisors and leave this outside the patient's mouth without having to fit it into the tubes, which helps a little bit with both time and patient comfort. Second Z bend is then started at this point and brought back so that we are duplicating on the patient's right-hand side what we have already created on the left-hand side. So we've got the basic utility arch with a step that goes. We've got the space that is distal to the lateral incisor on both sides, And we can then come back and measure the same distance on the right as we have on the left. As before, we will mark the overall span from the beginning of the loop to the beginning of the distal step, and then simply duplicate this on the opposite side so that we have relative symmetry to the arches. See the essence of the upper utility arch formed in a straight wire, measured exactly from the molar tube to the distal of the upper lateral incisor bracket, 2 millimeters away from the distal of the upper lateral incisor bracket, another Z bend, and another exact span. Now we can start to shape this and contour it. Rather than forming the anterior contour in this heavier wire with our forefinger and thumb, which would be very difficult to do, we normally use a contouring plier to form the anterior segment in a more ideal configuration. I'll put a little bit more contour at the upper canine area and then very lightly contour the posterior buccal segments. So you can see here that the upper utility arch has a little bit more ideal arch form to it. At this point, the bends on the buccal segments are straight up and down. We haven't started to add any flare to them, and the posterior legs are parallel to each other. We're now going to start to flare the anterior or the mesial to the upper molar outward, mesial to the upper cuspid inward. Again, we hold the upper utility arch at mid-bridge, and we'll take our forefinger and thumb and twist the distal portion of the leg. This will flare the posterior segment away from the tissue up around the upper molar. At the same time, we'll come forward and hold right at the lateral incisor region to bend the upper to flare the upper anterior portion inward. Of course, these are working against each other somewhat, so we have to balance it so that we maintain this outward bend here and yet an inward bend at the upper canine region. The wire essentially twists in the middle of the bridge and goes from an outward flare to an inward flare. Again, looking at the upper utility arch from the top, here you see the outward flare, the inward flare, the nicely contoured anteriors at 0-degree torque, the legs that are now parallel to each other. Quite often you'll find that by twisting out and then in at the canine region, you will have placed either buccal or lingual root torque on the upper molars. Before we put the tip back in, we want to bring these back down to 0-degree torque in the molar region. So we will compensate by holding at the vertical step and bringing it back down so that each of the posterior legs is at 0-degree torque. We then put about a 45-degree, 30 to 45-degree tip back in the upper molar region, and again place a great deal of distal rotation, upwards of 45 degrees. You have to remember this is a little bit exaggerated, but also as we place the arch wire, a great deal of it is going to be taken out in these lighter arch forms. So overcompensating is not going to hurt you in this area. So we tip it again, tip it up 45 degrees, bend it in 45 degrees, so that the final arch form has a very decided distal rotation on the upper molar. Just a couple of thoughts on torque control with the incisors and molars. To give you some idea, you can actually increase torque on the upper incisors by taking some of the bend out of the Z. In other words, by flattening out this portion on the top, what you're going to start doing is creating a bowing effect of the upper incisor region. So if we look at that, what you're going to start doing is adding more and more torque to the upper incisors simply by taking the Z out or flattening out part of the Z. Of course, this is a motion that we use to advance the upper incisors as well as torque them. And by simply flattening that out, we can place upwards of 30 to 40 degrees of torque in the upper incisor region. You can see how it's tipped up at this particular point. It flares and rainbows the upper incisors slightly, but again, in relationship to the overall plane, you can see that you start to put some torque in that area. Possible to increase torque in the incisor region by using an optical plier, and we'll put the conical beak on the gingival portion